Calciphylaxis. So calciphylaxis is a complication of chronic renal failure and dialysis in diabetics. And since a large proportion of patients having dialysis are diabetic, we see calciphylaxis. So it's something to do with calcium and phosphate, and the exact something is mysterious. But one of the treatments is to do a parathyroidectomy, and there are various manipulations of the dialysis fluid that are done, but it doesn't necessarily prevent it. So what happens in somebody with calciphylaxis is they get occlusion of the blood vessels of the lower leg, so it's a occlusive vasculopathy. So they present with these purple areas that break down into necrotic plaques and ulcers. There's a high mortality, because if it's occurring in the small vessels of the legs, it's probably occurring in the small vessels elsewhere in the body. And it can be recurrent. So calciphylaxis is treated rather badly with painkillers, local dressings, and thiosulfite intravenously. And we think that helps. So vasculopathies, occlusion can be due to blood, it can be due to cholesterol, it can be due to calcium, it can be due to thrombosis, vasospasm, trauma. But because it's occlusive, we don't have any inflammation going on, so it's not red. It can be secondarily red, but it doesn't start off red. There's a long list of things that can cause your blood vessels to block up. If somebody presents with a finger like that, it's actually quite difficult, I find anyway, to figure out, is it the smoking, which is Berger's disease, is it their rheumatoid arthritis, is it their systemic sclerosis, have they got infective endocarditis, a cholesterol embolus because they had a procedure last week. So cholesterol emboli, the clue there is they had a procedure last week, usually something like a cannulation of the coronary arteries. So actually I find these patients quite difficult, and they're usually assessed by the vascular team, and they find it quite difficult too, which is not a comfort, because I think I need to just be able to snap my fingers and say, that's that. It's not that easy. The next stage after that is they get dry gangrene, and then somebody chops the finger off eventually. Okay, so is it measles? We've got a sick patient with a wide spread rash. So when I prepared this, measles wasn't going around. It is now. So fever and a morbilliform eruption. So one of those is measles and the other one isn't. They look pretty similar, don't they? Red rash. So this is measles. That was a doctor who wrote to me on his recovery from measles and said, you haven't got very good pictures of measles. Would you like these? My wife took them during my illness. So that's what measles looks like, pretty much like a morbilliform drug eruption. But the patient is sick. They have a cough. They have conjunctivitis, and if they're an adult, they're often very sick. And of course, 3,000 people died this year from measles, I think, something like that. Not here. We had any deaths from measles this year? I know we've had some very serious complications, but I'm not sure if there's been any deaths yet. There will be. Don't go to South Auckland. So it starts in the face and then moves to the trunk. The colour changes. So in measles, it starts red, but then it goes purpley, copper-coloured before it disappears. You should be able to find Koplik spots. Now, honestly, can you see that? It's really hard. So if you do see any measles, please try to photograph the Koplik spots, because I have no good. That's the best picture I have. And I can't find any on the internet either. People, it must be really difficult to photograph. So this is not measles. So not as sick. No cough, no sore eyes. and you expect there to be a drug. Nearly always people know the drug. Some of our drug eruptions, it's the third person walks in the room and says, have you been taking any medicines? And the patient says no. And they say, oh, I took some cough mixture, does that count? It's usually the boss, you know, the registrars have taken the history, then I walk in. And they're so angry with the patient. You didn't tell me that. So urticaria can have small spots or big ones, and so we do sometimes get referrals about urticaria or morbilliform eruptions which have got them round the wrong way. So remember, urticaria is wheels, they're transient, they move around. And they're less common as a drug eruption. Mostly they're due to the virus for which you gave the unnecessary antibiotic. The antihistamines we use are cetirizine, loratadine, and fexofenadine. You can use any of them, they're all subsidized. I've added fexofenadine in there, but I've forgotten it isn't a 10 milligram dose. It's 180 to 240 milligrams once or twice daily, whereas loratadine and cetirizine are 10 to 40 milligrams once daily. You can split them if you like, and I often do split them because the patient is in control. You get improvement with antihistamine within 15 to 30 minutes, so they can be in control of what the dose is. So I'll say, you take 1 a day, that doesn't work, you take 2 a day, that doesn't work, you take 4 a day. But I might say take 1 or 2 once or twice a day. Urticaria often needs a full 40 milligram strength, which is off license. So the licensed amount is 10 milligrams daily. So if you're going to increase the dose, it's perfectly safe to do so. You need to say it's off license. If you need to increase the dose, that's fine. It often needs a bigger dose. Drug hypersensitivity syndrome starts as a morbilliform eruption, but the patient gets ill and they come to hospital and they often have this marked peeling reaction. And to get that degree of scale, it tells you that the rash has been present not less than 7 days. The drug was stopped. The rash is still there. And anyway, they don't think it was the drug they thought it was because they stopped it. And why hasn't it gone away? So it turns out that drug hypersensitivity syndrome, which we're seeing more and more of, but is actually uncommon, occurs up to 8 weeks after starting the drug. Whereas most morbilliform eruptions will start within a few days. And these drugs are a very small group of drugs. Allopurinol and the phenytoin carbamazepam group of drugs. What's the new one? It's not so new now. So there's a very low number of possibilities of drugs that will cause drug hypersensitivity syndrome, but they're very important drugs that haven't been replaced despite this nasty disease that you can get from them. It's genetic. And if you're Han Chinese, in particular, do not have allopurinol or carbamazepam without having your HLA status measured first. Because if you're carrying a particular HLA, I can't remember what it is, you will get drug hypersensitivity syndrome or toxic epidermal necrolysis, and you don't want it. There are genetic predispositions in other races too, but we don't have the test for it. We only have it for the Han Chinese. So they not only develop the morbilliform rash, but some other things happen too. So they get liver problems, lung problems, kidney problems, lymphadenopathy, hematologic problems. So one of the more recent ones I had was a call from another DHB. We don't know what to do with this patient. They've still got a rash. We stopped their drug a month ago. What do we do? And I said, well, what do your blood tests show you? And they said nothing. And I said, send them to me. And it wasn't nothing at all. The patient had a thrombocytopenia. That was the only systemic effect that the drug hypersensitivity syndrome head down. So we treat this with systemic steroids. We do not treat Morbilliform eruptions with systemic steroids. We do not treat toxic epidermal necrolysis with systemic steroids, except for sometimes we do. But this we always do, and they may need it for weeks to months, because it can take months for the disease to settle down. So if you can avoid allopurinol, avoid it. If you can avoid carbamazepine in particular, avoid that too. But there are a few other drugs that less common, like terbinafine, for example, can do it. Not often. We've had these pictures before, so toxic epidermal necrolysis, medical emergency, high risk of death. Don't confuse it with erythema multiforme, completely different disease. This is erythema multiforme, happy, charming, you know, laughing patient. How do you feel? I feel funny, I'm all right, maybe a little bit off school. I don't want to go to school today, I don't feel too well. But that's it, you know, they're talking normally. And they have a targetoid rash. They used to be thought to be all the same thing. This is totally different disease, but looks a bit similar. So what's a target lesion? A target lesion has three components: a center, which is red or blistered, a sort of skipped zone, and then an erythematous ring around that. The most common reason for targetoid lesions is urticaria. So most people who've been labelled as erythema multiforme had urticaria. They did not have erythema multiforme, which is uncommon. Erythema multiforme occurs in young people, slightly more common in males than females, usually as a response to a viral infection. The most common virus is herpes simplex labialis, but it could occur following a vaccination. It could occur following ORF. Those would be the three most common. It lasts 10 days to 3 weeks. The lesions are fixed. They don't move around. They occur on the hands and feet, maybe the knees, maybe the cheeks. There's a subtype which is no longer probably called erythema multiforme, which is a reaction to mycoplasma, and that's kind of a hybrid between erythema multiforme and Stevens-Johnson syndrome, so it's even more confusing because they might get mislabeled as all sorts of things. So remember mycoplasma, it causes pneumonia and a rash. So something like 40% of people with acute mycoplasma pneumonia have a rash of some kind. There's lots of different rashes they can have, but this is one of them. Target lesions. Now, if you've got very bad erythema multiforme, it's called erythema multiforme major, and you get oral blistering or penile blistering. So it's another confusion with Stevens-Johnson syndrome, but it's a different disease. This patient is relatively well. Atypical erythema multiforme might be a drug rash, it might be not erythema multiforme at all, but somebody's labelled them with that because they can't think what else to call it, or it might be a paraneoplastic phenomenon. Bit different from toxic epidermal necrolysis, where the skin just peels off and it's agony. The one on the right survived. Well, both of them did survive, actually, both those two. And the one on the right was in intensive care for a long time. She went home. She had 2 serious complications. She was blind. Never hasn't been able to work again. And her vagina was occluded. She was operated on, and that sorted that problem on. So it's a very serious disease, even if you do survive it. Next, fever and a rash. Is it meningococcal disease? So the ambulance have picked him up. He's febrile and he's got some purpura on his lower legs. They're not going to muck around. They're going to call this meningococcal disease anyway. He will be treated immediately with penicillin. So the purpura could look like that, which is flat, macular. So that's bleeding into the skin. So that's more likely to be a low platelet count or something wrong with your platelets. Platelets aren't working properly. Or else the skin is really thin and the blood vessels are just breaking under the skin. So meningococcal disease, I've got hardly any pictures because I'm a dermatologist. And despite asking our emergency department, please send photographs, unfortunately their patients aren't well enough to get consent. And they're too busy to remember to take photographs. We can get the consent later, I'm not too worried about it, just take the photos. How are we to educate the world if we don't have pictures of what purpura looks like in meningococcal disease? So it's not palpable, it's bleeding into the skin. The bleeding tends to be acral, so meningococcal disease can lose you can lose your digits and things from occlusion. Purpura fulminans, bleeding into the skin, much more widespread. DIC, disseminated intravascular coagulation. Spreads very rapidly, patient very sick. Now, I see the person who's just a little bit unwell and has an acute hypersensitivity vasculitis. So we've got inflamed blood vessels due to immune complex deposition. So this is a reaction. So they had something and now they've reacted to the something with a vasculitis. These are small vessels vasculitises. So we would see at least one patient a month presenting to our clinic with an acute hypersensitivity vasculitis. They're unwell, they're sometimes admitted to hospital, not always. And in half the cases we figure out what did it, and in the other half we never find out. So our investigations are twofold. One, what caused it? Two, what harm has it done? So we take a history, we examine the patient. But often there's lots of things going on. Oh, I've had this, that, and the other, and I was given this, that, and the other medicine, and you can't really work it out. So infections can do it, autoimmune diseases can do it, cancer can do it, procedures can do it. So the one on the left was quite often young. So the one on the left was a young man who presented with a sore throat, went to his doctor, tested for strep, had an acute group A strep, confirmed, treated appropriately with a penicillin antibiotic, and a week later came out with an acute hypersensitivity reaction. Was it the drug or was it the group A strep? Well, it's much more likely to have been the group A strep. So that though antibiotics can cause leukocytoclastic vasculitis or acute hypersensitivity vasculitis, this is the same thing. The leukocytoclasis is a histologic term. It's much more likely it was the infection. So we know that when you get a strep throat, you develop antibodies and you can test them in the blood, and they go up and up and up. You test them again and they're still rising, and then they start to fall. And they fall over several months. So don't be surprised that your immune complex reaction is going to last several months. So we tell people at the beginning, so they don't get any surprises, that this is going to go on for several months. And they get crops. So they get a crop of new lesions, settles in another crop, another crop, another crop, and then they go away. And that takes a few months. So what we want to do is to minimize harm. So if you've just got little spots like that, there's no need to actively treat it because it's a minor thing. And our treatment isn't going to change the course of the disease. It's going to last several months. We can't stop that. So, but we're going to treat this guy because he's getting ulceration, and that will cause scarring. So he will be given systemic steroids, prednisone, until it's worked, and then we'll try getting him off it. And if we can't get him off it, because every time we drop the dose, more crops occur, and we know we've got several months more to go, we're going to prescribe dapsone or colchicine, and neither of those are drugs we use in general practice. So we would expect this patient to be in dermatology. So now our other tests are going to be, what harm has this done? And in dermatology, we mainly see people with cutaneous disease, and we don't find any harm anywhere else. But we're looking particularly for kidney disease, because vasculitis causing kidney disease is very serious. And Henoch Schonlein purpura is a variant of acute hypersensitivity vasculitis in which IgA is involved instead of IgG, tends to occur in younger people, and has a higher risk of renal disease than the usual case. Can't tell the difference clinically mostly, although people will pretend they know the difference. There isn't all that, it's not all that easy to tell. So we always look at the urine. We're looking for casts, we're looking for blood, we're looking for white cells. And we will test it weekly for several weeks. We'll do a few blood tests, and we may repeat them from time to time too. But mostly, if you're going to get kidney disease, you'll get it in the first 2 or 3 weeks of the illness. So after a few times checking the urine, if it's okay, we'll stop doing that. Now, in the Waikato, if we have any systemic involvement, they go to the vasculitis clinic, not dermatology, and that's run by rheumatology. It'll be different in different parts of the country, but that's what we do in the Waikato. So rheumatology look after the systemic disease, we look after the cutaneous disease. Mostly lower legs and feet, but you can get involvement of other parts of the body sometimes. See, you've got a big blister there? Now that's probably going to cause an ulcer, so blisters we'll also probably treat. Now this is Henoch Schonlein purpura, supposed to be less likely to blister, less likely to ulcerate. Next case history. Red man. Got a fever, he's shivering. He's dehydrated, and he's got a rash all over. He's now gone into heart failure. We don't know which ward to send him to. Do we send him to the heart ward or the skin ward? We don't have one. What do we do? And we call the dermatologist, but it's Friday, and then we don't work at weekends, so it's Monday by the time we get there. Okay, so what we've described is erythroderma, which can be acute or chronic. Erythroderma means red skin all over. Now you can have skip areas. So this red all over's got skip areas. And skip areas are a clue to diagnosis. But mainly we get called and we just see red. And if it's been more than a week, we'll see some surface change. So some scale, if it's been there for more than a week. So probably the most common is a drug eruption, and it may start as morbilliform, but it didn't stay morbilliform. It became generalized and red all over. No skip areas. The other most common group is we know what's wrong because they have a pre-existing skin disease, which has just gone bananas. And that's usually atopic dermatitis. And a common scenario is the patient is fed up because none of the treatments work, so he stopped them and ends up in hospital. And then perhaps it might occur to them that maybe it was working a bit after all. But half the time the patient will say it's those drugs did it to me, but actually the drugs were saving him from doing it before. Psoriasis. So severe psoriasis can become erythrodermic. Those patients are usually quite well with their erythroderma because it's a gradual process, their skin's got used to it, and they're not so ill on the whole. Pityriasis rubra pilaris is a rare condition that looks a bit like psoriasis, but it isn't, and causes erythroderma. And one of the forms of cutaneous T-cell lymphoma, which is called Sézary syndrome, is erythroderma due to malignant T lymphocytes in the skin. Now all of those look the same. They all just present with red skin. and an unwell patient, although, as I say, the psoriasis, they don't tend to be quite so unwell, unless it happened very acutely. So last week, I saw a patient who wasn't erythrodermic, but she told me that last time she had a flare-up, she was. And she said she went into her bedroom and found her husband hanging from the ceiling. And she said, "Do you think stress can cause psoriasis?" And I said, "You've just told me that stress causes psoriasis. What was your stress this time?" And she had some stress this time. So the body works in mysterious ways, but it didn't really help her recovery, of course, from an awful event. And I've had 3 patients now who've given that same story. So psoriasis can be quite a thing. So which one did it? We're often faced with this problem, aren't we? People are multi-medicated and we don't know which one is the cause. So these are 2 different patients who presented with erythroderma due to drug. There's nothing special about it. They're red and scaly all over. They're ill. So high output of cardiac failure is right-sided heart failure. They have high pulse rate, and basically the heart can't keep up with getting the blood to the skin. So they get protein enteropathy, so they get low albumin, can't produce, the liver's working hard to produce enough skin to replace the skin that's being inflamed and sloughed off. They can get dehydrated and they can get renal failure from that. And so it can make people pretty ill. And what we do is we cool the skin. So we put ice on it, basically ice packs, get rid of that redness. Wet wraps, cool the skin down. And then they'll stop shivering because then the core can warm up. Because they get really, really cold because of their hot red skin. Because all the blood's rushing to the skin, there's nothing left to warm the insides. So you need to cool the skin down to allow the central core to warm up. So you need to be in a temperature-controlled environment. Atopic dermatitis, you can smell them. So this is erythroderma with a smell. The skin is oozy and sticky, and you're smelling serum. And they stick. If you've got paper sheets on your, we don't have paper sheets. We have sheets. But those paper pull-on sheets on your examination table, they only need to be lying on it for a few minutes, and they're soaked through, because they're just pouring out serum, shivering, very, very ill. And as I say, it's usually topical steroid or systemic steroid withdrawal or cyclosporin withdrawal. But sometimes they're completely untreated. They will probably have an eosinophilia. They'll probably be anemic. And they'll be miserable, absolutely miserable. The psoriasis patient, less miserable, but they can still have heart failure. Red all over. So this man, you can only see a bit of him, but he came to me in my private rooms and was erythrodermic, and he walked in, perfectly healthy really. I took his clothes off, and as he did so, his skin fell off. So I took a photograph of him standing there with the skin on the floor. There was a patient, when I was in London, they measured with a bag. They had an erythrodermic psoriasis patient who was in hospital. At that time, he'd been in hospital for 3 months. And they'd been collecting his skin in polythene bags and weighing them. So generally, they know they've got psoriasis. They tend to have this silvery scale as opposed to, and it's not sticky, it's dry. But they not very happy usually. PRP looks pretty similar to psoriasis, but they have the skip areas. Do you see how you almost see the white more than you do the red? It's the red that's abnormal, but it's the white you see. It's very folliculocentric. Do you see how these red areas are focused on the hair follicles? Starts in the scalp and works down over a few days. So it's an acute erythroderma looking like psoriasis, but not quite right for psoriasis. It lasts 2 years and then it goes away. What causes it? Haven't a clue. The most recent one I saw had Prevnar vaccination a few days before his acute rubra pilaris, and we think that probably did it. It was a vaccination precipitated. But there's no way you can prove that. We weren't going to give it to him again. Affects these very striking skip areas. Affects the hair, so you can lose your hair, and affects your nails. And it causes an orange appearance and thick skin, so you can hardly move your hands and feet because the skin is so thick. They're like that, and they're orange. Can occur in children, less severe, and less often. Cutaneous T-cell lymphoma, it just looks the same. So we always need to biopsy our erythrodermic patients. Always thinking, is this psoriasis? Is it eczema? Is it drug eruption? Is it cutaneous T-cell lymphoma? And sometimes we need multiple biopsies over multiple periods of time. And you can have 2 diagnoses. So one of our atopics, very severe atopic dermatitis, no question about that, developed cutaneous T-cell lymphoma. And it took a while to diagnose because we were just treating his eczema and nodding away and saying, yeah, I know it's really severe, you know, let's try another drug. But it was, in fact, lymphoma in the end. So the hair falls out, the nails can do weird things, and you die. It's not treatable. Well, it's treatable, but it don't work.